Hi there, my name is Pillemer and I'm an orthopaedic surgeon with a particular interest in impairment assessment. What I would like to discuss is the very common condition of shortening of the lower extremity and to highlight the difference between true and apparent shortening. Usually on one's first day as an orthopaedic registrar, and certainly within the first week, one needs to know all about shortening as it is so common and so important. I'm aware that this does not apply as emphatically in other specialties. With regard to the methods of measuring for shortening, the most commonly described method is to measure the distance from the anterior superior iliac spine to the tip of the medial malleolus with the patient supine as shown here. However, I find the standing method using blocks as being more accurate. I use these blocks of 1/2 centimetre, 1, 1.5 and 2 centimetres so that one gets 1/2 centi increments up to 5 centimetres. There is also a 5 centimetre block. The next few slides will show how accurate this method is. Here is a person with equal leg lengths and you can see the fingers placed on the iliac crests are at the same level. In this slide, the right side has been raised on a 1 centimetre block and look at the obvious difference. And here raised 2 centimetres. This is a very accurate way to measure leg lengths. I will always check my measurement with the patient recumbent using the anterior superior iliac spine to medial malleolus method. Now we come to the slightly confusing true versus apparent shortening. If you look at example B, you can see that the left leg is shorter than the right. If you can then confirm that the pelvis is square and the legs are parallel, then you have what is called true shortening. If you look at example A, the diagram on the left shows an adduction contracture of the left hip, such that when the pelvis is square, the left leg crosses over the right leg. There is no way that the person can walk in this position, and the only way he or she can walk is to get the legs parallel, and the only way to do that is to hitch the pelvis up on the same left side. The person can now walk, and the legs are parallel, but the pelvis is not square. So the left leg appears to be short, even though it is not. This is what is termed apparent shortening. The way to measure apparent shortening is either by using blocks or measuring from a central landmark, such as the umbilicus or the xiphisternum. In this example, the man in the diagram on the right has a fixed adduction contracture of his right hip, and the only way he can get his legs parallel in order to be able to walk is to hitch his pelvis up on the right side, giving apparent shortening. And in this final slide, the man on the left has a fixed abduction contracture of his left hip, and the only way to get his legs parallel is to hitch up his pelvis on the opposite right side, giving apparent lengthening of the affected leg. I have discussed a number of other clinical signs and items of interest in assessing impairment in my YouTube series. Click on the link below. Stay well.